With that being said, I would like to introduce Annie Buck, who will be joining us today and giving us this beautiful presentation. Annie Buck is a doctoral candidate in the Department of Health, Law, Policy, and Management at the BU School of Public Health. Her research sits at the intersection of trauma surgery, public health, and social justice, with a focus on firearm injury prevention and gun policy at both the state and national levels. She serves as the resident advocacy chair for the founding chapter of socially responsible surgery at the Boston Medical Center and is completing her dissertation on the expansion of Massachusetts red flag laws to include clinician practitioners, a project funded by the Massachusetts Attorney General's Office. Nationally, she also serves as the co-chair of the Student and Early Career Professional Committee for the Society for the Advancement of Violence and Injury Research, SAVIR for short. Annie earned her BA in philosophy with a concentration in bioethics from Georgia State University and her MS in clinical research from BU School of Medicine, where she is now an academic program manager for the MSCR program and instructor in research ethics. Thank you, Annie, for being here today. We are so grateful to get your knowledge. I'll pass that over to you. Just again, as ground rules, we do have some prepared questions, and then we'll open it up to questions from you all. Please pose them in the chat as the presentation is going on. And with that, I'll pass it to Annie to take it up.
Great. Thank you so much, Ruth and Alex. All right. Can everybody see my slides? Thumbs up. Awesome. Well, thank you for the kind introduction. My name's Annie Buck. I'm a doctoral candidate at the BU School of Public Health, and I'm really excited to talk to you all about some of my dissertation work focusing on bridging healthcare and public safety in Massachusetts through the use of extreme risk protection orders. When we talk about firearm injury and violence, I think it's really important to ground ourselves in the data. So, on average, nearly 47,000 people die by firearms each year in the US. And the majority of those deaths, approximately 57%, are suicides. Another 40% are homicides, followed by police-involved shootings, unintentional, and undetermined deaths. For the purpose of today's conversation, I'll be focused on gun suicides and gun homicides. And these matter in healthcare because suicide and violence risk often intersect directly with clinical care. Moments of crisis, acute injury, mental health distress, or escalating risk frequently show up in hospitals, clinics, and emergency departments. Now, I don't think I need to reiterate that suicide by gun is a real issue, especially for us here in the Northeast. A Johns Hopkins Bloomberg School of Public Health report published in June of 2025 evaluated the completed CDC data from 2023, and in the US, suicide by firearm were at record levels for a third straight year, with 58% of total firearm fatalities in 2023 being due to suicide. Gun suicide rates are higher in rural states compared to more urban states, with Wyoming having about 10 times the gun suicide rate of Massachusetts, which has the lowest gun suicide rate. And even though in Massachusetts we have that low rate, that does not give us license to be complacent. There's always work that we can and we should do. Massachusetts has taken a comprehensive legislative approach to firearm injury and violence prevention. The state's long prohibited assault weapons, bump stocks, high capacity magazines, and it requires background checks as well as secure storage and child access prevention. ERPOs fit within this broader policy framework, but they are distinct in an important way. They're individual level, time limited, and risk based. So rather than regulating weapons broadly, ERPOs focus on moments of acute risk and create a legal mechanism to temporarily separate a person from firearms during a crisis. This is where healthcare becomes particularly relevant. Clinicians are often the first to identify escalating risk, making ERPOs a natural extension of existing safety and prevention efforts. Now, from a public health perspective, firearm injury is preventable. We understand violence as a contagious crisis, not something that occurs in isolation or in a vacuum, and importantly, not solely a criminal justice issue. Public health responses emphasize interventions that are data-driven, community-based, systemic, rather than reactive or punitive. And in 2018, the head of the NRA told clinicians and public health officials to stay in your lane, which received swift and public backlash, leading to thousands of healthcare professionals publicly stating, "This is our lane." Caring for patients means caring about the conditions that put them at risk. And the public discourse between the NRA and clinicians nationwide led to the Brady formation of the This Is Our Lane coalition, led by Dr. Joseph Sakrin, mobilizing healthcare professionals to focus on nonpartisan public health solutions to combat the gun violence, injury, and suicide epidemic. And that framing was further solidified in 2024 when the US Surgeon General formally declared firearm violence a public health crisis. ERPOs align directly with this approach by offering a prevention-based, time-limited intervention that addresses risk at the moment that it matters the most and that places healthcare squarely at the center of safety. So I've mentioned ERPOs a lot, but now I think it's important that we actually define them and what they are. Extreme risk protection orders, or ERPOs, are one of the tools many have to help prevent firearm injury and suicide by gun. And these are also often referred to as red flag laws. An ERPO is a civil order that temporarily removes firearms from somebody who poses a risk to themselves or others. And it can be issued in an emergency or after a court hearing and extended if needed. ERPOs are important because research shows about 1/3 of mass shooters exhibited warning signs. And as you saw in a previous slide, most gun deaths in the US are now suicides, roughly 140 per year in Massachusetts alone. Right now, 22 states and Washington, D.C. have ERPO laws, and 7 states plus D.C. allow clinicians to petition for them directly on behalf of at-risk patients. And in exciting news, Maine voters just approved their own ERPO law, showing continued momentum for these life-saving policies. Massachusetts enacted its ERPO law in 2018, initially allowing only family or household members to petition the court. There was no age limit for the respondent, and petitioners had the right to legal representation during hearings, reflecting an early emphasis on due process. Now, over time, it became clear that this narrow petitioner pool limited ERPO use, particularly in cases where clinicians were often the first to identify acute risk. In 2023, the Massachusetts House passed legislation that expanded ERPO petitioning authority to include licensed clinicians. And that effort continued into January 2024 when the Senate amended the bill with the stated goal of passing comprehensive gun policy by July of 2024. Now, this evolution marks a critical shift, recognizing clinicians not only as care providers, but as essential partners in firearm injury, violence, and suicide prevention, positioned at the intersection of healthcare and public safety. In July of 2024, with massive support from the coalition, Massachusetts passed the Gun Omnibus Bill, H 4885, marking a major shift in the state's approach to firearm injury prevention. Now, one key update was that the ERPO law now applies to all Massachusetts residents and not just current firearm license holders, therefore broadening its preventative reach. And most notably in the healthcare space, the law expanded who can petition for an ERPO. Licensed clinicians who have treated an individual within the past 6 months are now eligible to petition alongside school administrators across K through 12 and higher education. So this change formally recognized that clinicians and educators are often the first to identify escalating risk. By expanding petitioning authority beyond the home and into clinical and institutional settings, Massachusetts explicitly positioned ERPOs as a tool that bridges healthcare, education, and public safety, embedding prevention into the systems where risk is most likely to be identified early. The bill was passed on July 17th, it was signed on July 25th, and then an emergency preamble was signed October 2nd, all in 2024, immediately enacting the entirety of the bill, including the ERPO petitioner expansion. So at this point, you might be asking yourself, why did we need to expand the petitioner categories? Aren't concerned family and household members enough to file these? Is this becoming too complicated? So thanks to the Massachusetts Trial Court's data dashboard, you can see the numbers for yourself. Only 90 ERPOs have been filed from 2018 when the legislation was first enacted through 2024. Now we can only speculate as to why the numbers are so low. Is there not enough messaging, and do people not know about ERPOs and how to use them? Is the process too cumbersome? Are family and friends of a loved one in crisis or at risk worried about their personal relationships with the respondent? And honestly, your guess is as good as mine, but no matter what, we still have on average 267 gun deaths per year in Massachusetts, and approximately 140 of those are suicide by gun. Now, this dashboard shows what ERPOs actually do in practice. So from 2018 through 2024, between 65 and 70 firearms were surrendered in Massachusetts following ERPO petitions. Now, while the absolute numbers may appear small, each surrender represents a moment where access to a lethal means was temporarily interrupted during a period of elevated risk. And it's important to note that these surrenders occur across both emergency and non-emergency contexts. That reinforces that ERPOs aren't solely crisis responses, but they're part of a broader preventative infrastructure. Now, from a healthcare perspective, this is really meaningful. ERPOs function as a time-limited upstream intervention that creates space for stabilization, for treatment, and often even for connection to care, which demonstrates how clinical risk identification can translate into tangible safety outcomes. So now let's take a look at how ERPOs are actually being used across the Northeast. Now, when we look at the number of ERPOs filed across states in the year 2023, it's important to remember that these numbers reflect more than just policy differences. They also mirror state size and firearm ownership rates. For example, New York, being a larger state with more residents and higher number of firearm owners, reported 5,074 ERPOs filed. Whereas Connecticut, while being smaller, has a 10-year advantage of the law being implemented, and they had 2,131 ERPO petitions filed in 2023. Their higher numbers reflect both broader populations, but also more opportunities for intervention. Now, less populated states or states with lower firearm ownership rates like Rhode Island, Vermont, and Massachusetts naturally report lower totals, 53, 36, and 11 petitions, respectively. But that doesn't necessarily mean that the laws are less effective. Instead, it highlights how population size, firearm prevalence, and awareness of ERPOs all influence utilization rates, giving all of us the opportunity to build out the awareness of the legislation. And again, very exciting news. Maine voters just approved their own ERPO law in November, marking another step forward for firearm injury and suicide prevention in New England. Meanwhile, New Hampshire remains the only state in the region without such legislation, which offers an interesting contrast as we think about policy diffusion and regional approaches to gun violence and suicide prevention. So now, what do we actually know about how ERPO laws are working? The RAND Corporation has conducted one of the most comprehensive and ongoing systematic reviews of gun policy research in the US. Their most recent update, the fourth edition, which was released in July of 2024, it analyzes the existing scientific evidence on ERPO implementation and outcomes. So here's the big picture. For most categories like mass shootings, police shootings, violent crime, and unintentional injuries, the evidence is still inconclusive. Now, this isn't because ERPOs don't work, but because the laws are still relatively new and the data just isn't mature enough yet to meet RAND's strict inclusion criterias. But what we do have emerging evidence for is suicide prevention. RAND found limited but promising evidence that ERPOs may help reduce suicide risk, which aligns with what many clinicians and policymakers are observing anecdotally in states where these laws are being used. So, in short, there's a growing body of research, but we still have work to do in evaluating these laws systematically. And that's why partnerships between researchers, clinicians, and policymakers like ours are so important for expanding the evidence base. But while this legislation was in the works, and before the bill was even passed in 2024, we took the opportunity to take the temperature, if you will, at the busiest level 1 trauma safety net hospital in New England. Boston Medical Center sees approximately 70% of all penetrating trauma in the Boston metro area, and depending on the year, 30 to 40% of all gunshot victims in the state. So it was a really important population to assess prior to the proposed legislation passing and what the impact may or may not be for our clinicians and patient population. This was an IRB approved study with appropriate sign off at all levels. My team developed a validated anonymous survey that was distributed via email listserv to clinical specialties that would be likely to assess and address firearm risk and safety in their patient populations. And this included trauma acute care surgery, the community violence response team, OBGYN, pediatrics, family medicine, psychiatry, and emergency medicine. And the survey examined 3 areas: knowledge of ERPO legislation, comfort when using legislation in the legal system, and perceived barriers to engaging with ERPO legislation. We had A 14% response rate. We're very grateful. I know how much and how little time busy clinicians have to engage in this kind of work, with the top participating specialties being trauma acute care surgery, pediatrics and psychiatry, behavioral health. Unsurprisingly, 79.5% of respondents were unaware or unsure of a Massachusetts ERPO law even before the expansion passed. And when informed of the possibility of clinician petitioning, 80.8% of the respondents reported that they would be somewhat or very likely to file an ERPO for a patient at extreme risk for violence or suicide. 21% of clinicians reported an encounter with a patient in the last 6 months who they believe should have their weapons removed. And the result that gave us the most pause and really drove home to me the importance and the gravity of this work was that 9.3% of clinicians reported they encountered patients daily who were at extreme risk of violence or suicide. Now, taking that into consideration with the fact that there were only 11 ERPOs filed in Massachusetts in 2023, we very, very quickly realized that the state or trial courts may not be ready for the influx of petitions should this law have passed. Noted barriers to clinician petitioning, if it were made available, included a lack of knowledge, time constraints for attending court hearings, filing paperwork, concerns about negative impacts to patient or client relationships, and over a quarter of respondents indicated a general lack of trust of the legal system. So we dug a little deeper into the need for clinician-specific education, and again, unsurprisingly, 96.7% of the respondents cited the need for clinician-focused ERPO-specific education prior to being comfortable filing one. When given the opportunity to further describe what the education should look like, clinicians requested that it be voluntary, online, CME accredited, and some also requested specialty-specific grand rounds. So the team at BMC leveraged that survey data, and in 2025, the Massachusetts Attorney General's office very generously awarded funding to support new public health models for gun violence prevention, including a grant to Boston Medical Center. And this represented a really critical step in bridging healthcare and safety, moving ERPOs from statute to bedside by equipping clinicians with the knowledge and the tools needed to act during moments of crisis. And so, with the survey data and generous grant funding from the Massachusetts Attorney General's office, we responded. Boston Medical Center, in collaboration with the Massachusetts Medical Society, developed a fully online 1.25 CME accredited clinician focused ERPO education. Now, this education is 3 modules narrated by the Boston Medical Center Chief of Trauma Acute Care Surgery, Dr. Tracy Deckert, and this is available for free to anyone, regardless of clinical licensure, clinical specialty, or geographic location. However, it is focused on the Massachusetts law and procedures. The education became available on September 22nd, 2025, and we were thrilled to see 48 individuals started the course in its first week of availability. Now, hopefully, after our conversation today, we'll see those numbers continue to climb a little more. And additionally, we have developed validated anonymous surveys evaluating the education and also post-education clinician usage of ERPO legislation that we really highly encourage everyone to participate in. I know everybody's time is really, really valuable, so we've ensured that the average completion time for each survey is approximately 3 minutes. The results of these surveys will be used to continually improve the education, but also they'll be shared with state legislators in Massachusetts, but also in neighboring states for the continued growth of ERPO legislation and processes to better support clinician and healthcare system participation with the ultimate goal of keeping our patient populations and their communities safe. So here's the real big question. What do we do now? So at present, clinician-initiated ERPO filing follows the same procedural pathway as prior petitioners. Clinicians complete the standard forms, submit the required documentation, and if an emergency order is issued, law enforcement serves the respondent and facilitates firearm removal. Hearings are then scheduled within the statutory timeframes for both emergency and non-emergency orders, including when a petition is denied. That being said, something I want to emphasize today is that this process was not originally designed with clinical workflows in mind. So as clinician involvement increases, it's likely that some aspects of this process will eventually evolve, whether through streamlined forms, institutional support, or clearer guidance tailored to healthcare settings. The current moment is both an implementation challenge, but also a great opportunity to shape a process that better integrates healthcare and safety. So I would like to close with a clear call to action. This is our lane. Let me say that again. This is our lane, collectively for patients and clinicians. Firearm injury and suicide prevention sits squarely at the intersection of healthcare, public health, and safety. So, for patients, that means having open, honest conversations with your clinicians about safety and risk. And for clinicians, this means starting those conversations with patients, with colleagues, within our healthcare systems, and being willing to use the tools available to us, including ERPOs, when risk is high. Beyond the clinical setting, engagement really, really, really matters. As Ruth and I have talked about many times, it's about the conversations. Get involved with efforts like the Yes for a Safer Massachusetts campaign, stay informed, and always, always, always get out and vote. Prevention requires preparation at every level, and each of us has a great role to play in keeping our communities safe. And with that, I'd like to thank Ruth and the coalition for having me today, and I'm happy to answer any questions.
Thank you so much, Annie. We greatly do appreciate that informative and insightful presentation. I surely did learn a lot. To begin with our first prepped question, can you reflect on how you became involved in advocating for this bill and what that process of engaging in legislative advocacy has been like for you?
Yeah, so I had briefly started looking into ERPOs as a policy that really needed to be studied in, I think, August of 2023. And then in September of 2023, everything really kicked off with an advocacy day that I attended at the State House that was hosted by the coalition. I like to tell people that going to the State House was a little like ripping off the Band-Aid, and it really made policy change and engagement with the legislative process less foreign and more tangible and real. And I think from there, it really took off when the coalition invited me to testify at both the House and the Senate hearings for the omnibus bill. Um, Engaging in legislative advocacy has been both, I would say, challenging, but also really deeply affirming. I think it required me to quickly hone the skill of translating evidence and lived experience into language that resonated with policymakers, but also needing to listen really carefully to the concerns from across perspectives on both sides of the issue. Um, what stayed with me the most is how collaborative the process can be and how much I really, really enjoy bringing together clinicians and researchers and advocates and legislators, and bringing everybody together towards a shared goal of safety. It really reinforced in me kind of that thoughtful, data-driven advocacy can be a really powerful extension of public health work.
Yes. Thank you for sharing and lovely to hear. I think unofficially at the coalition, I think all of us have began with a state house visit. So I think it's lovely to hear how that impacted you as well. Question two also focuses on the advocacy. So like what has it been like to engage in advocacy specifically around this bill? And why is that researcher practitioner involvement so important and essential? And specifically when it comes to the implementation that you talked about, how do we ensure medical and mental health providers are equipped to take on that role?
Yeah, I think engaging in advocacy around this bill has both been really, really exciting, but also incredibly humbling. It really meant stepping outside of a traditional academic and clinical space that I felt very comfortable in, and getting into some really deep, hard conversations where evidence, values, real world constraints all kind of converged. And sometimes that isn't perfect and it doesn't feel warm and fuzzy. But what's been most meaningful, I would say, is seeing how policy becomes stronger when it's informed by the realities of practice, by workflows, ethical considerations, support needs that clinicians actually are facing on a day-to-day basis. Um, And I think researcher and practitioner collaboration is critical. People hear me say this all the time. I won't publish a paper that doesn't have a clinician on it because I want it to be rooted in what's actually happening. Because implementation doesn't happen on paper. It doesn't happen in a vacuum. It happens in clinics, it happens in hospitals, community health centers, and community spaces. Clinicians and mental health providers, they need clear guidance, they need training, they need systems level support to really take on this role. And without that input early on, well-intentioned policies can then just sit on a shelf and gather dust. So whether researchers and practitioners are engaged in collaboration from the outset, implementation becomes more feasible and more equitable and ultimately more impactful for patient safety.
Thank you so much, Annie. And I just want to say again, I have another question I'm going to pose, and we're going to open it up to questions from all the folks who are joining us today. But I really want to reflect about how meaningful it was for me in my role at the coalition to have you partnering with us and showing up with us at the State House for this advocacy. Um, our partnership has really had an impact on the coalition. It's had an impact on me. And I just am really grateful because I also, you spoke to the challenges of practitioners having time to do all of these things. It also takes a lot of time to show up at the State House, especially when you have no idea how long it's going to take. So your investment of time, energy, and resources into this process was really meaningful, and we're very grateful for it. So thank you. And before we open it up to questions from the audience, just one other question that we wanted to pose to you, and it touches on a bunch of things that you have mentioned already, but to get a little more granular around what you are hoping that the folks who are joining us today will take away from our Lunch and Learn today in this conversation about the importance of this legislation, and also speak to the importance of implementation and the role of implementation, how researchers and clinicians and practitioners can all be involved in that process from advocacy through the passage of the bill and through implementation. So there's like 14 parts in that question, but I think that you know what we're getting at.
Yeah, no, that's a really great question. I really hope participants leave today not just feeling informed and empowered, but also hopeful and curious, curious to have these conversations with their clinicians, and clinicians being curious to have these conversations with their patients. The bill really matters because it creates real opportunities to prevent harm, but the impact is ultimately going to depend on how thoughtfully it's implemented and supported in practice. My hope is that researchers, clinicians, advocates all see themselves as essential and equal partners in this process because each is bringing a really unique perspective. It's kind of like assembling the Avengers. Everybody's got their superpower, and all that does is strengthen the work. And I want people to feel encouraged to engage in ways that align with their roles, whether that is through research or conversation or education or advocacy, especially with the coalition.
Thank you so much for that. Yeah, very insightful, and I hope we all continue to work away on this. Continuing now on to the audience questions, and please, audience, please feel free to continue posing your questions in the chat. The first one is, do we know if the state plans to put out PSAs or public billboards? The lack of information provided to the public is a huge obstacle preventing these important laws from being useful.
Yeah, great question. Messaging is a huge deal with any legislative mandate, and I think I'm unaware of any state-sponsored messaging campaign around this. But I'm certainly interested in reaching out more and finding out if there is any plans for any kind of messaging campaign around this. I know it's very, very important to the Attorney General's office. that people know about this. And I think there's going to be a lot more messaging, maybe not necessarily from the state, but from the Yes for a Safer Massachusetts campaign going forward.
And if I can just jump in, we'll be talking more about the campaign momentarily. So that was a good lead in. Thank you, Annie.
Anytime.
Um, but I think one of our collective action steps, and has been, and we have been doing this at the coalition, reaching out to the Department of Public Health and to state officials to understand what the plans are for implementation and what that is going to look like in the midst of obviously so many things happening statewide on a federal level that impact the state. There's just so much going on. But I think a lesson learned, and I'm looking at our friends on the screen who were involved in 2018 when the first ERPO law was passed. And one of the lessons learned is that we didn't really have a robust implementation plan on the state level, and that may impact utilization because folks are not going to utilize legislation if they don't know what's in it. Um, and I'll also just reflect for a moment on my history as someone who did domestic and sexual violence work for many years and was kind of in the first wave of folks training medical providers on screening for domestic violence. Um, and that is, it's not something that happens magically overnight. It's something that folks need to talk through and practice and figure out protocols. So there's implementation in terms of general awareness, but one of the things that I so appreciate about Annie's work is sort of getting into the weeds of what the process looks like, how to have the conversations. This is an evolutionary process. And so sometimes the first touch point with education about something like this just needs to be the first touch point. It needs to continue. Um, and so having a plan statewide, having folks talk to their own medical professionals around the importance of this, and we'll talk a bit more about that. I think there's a lot that needs to go into a good implementation plan to make sure that the legislation lives and is being utilized by folks.
Thank you, Ruth. Fully agree. Next question from Jenny was, of the 11 ERPOs in 2023, what was the timing between filing a petition and the removal of firearm? Seems like the process might take a little too long to be effective.
Yeah, great question. There's a lot of the data dashboard that the Massachusetts Trial Court provides is pretty comprehensive, but not that granular, I would say. But the law that's on the books is that there needs to be a hearing within 7 business days. And so depending on whether it's an emergency or it's a regular filing, I'm unaware of what the timing would be between the approval. I would assume that an emergency order, um, you know, there's a judge that's on call 24/7, and that order would then be made, and then it would be handed off to law enforcement to carry that out. When they do that, I'm unsure of what the timing would look like on that. So um, I don't know specifics about each of those 11 filings. And I don't know if that's something that is made public or would be made public by the Massachusetts trial courts. However, with the expansion of the need of data in the omnibus bill in 4885, that is something that we could potentially ask the trial courts to elaborate and get a little bit more granular in what kind of data they're willing to provide, and finding that balance between privacy of the respondents and petitioners as well.
Thank you. And then one final comment, and then I will get to Jack. Don't worry, I see your hand up there. So who are included in the term clinicians?
Great question. So the way that the law is written, it says licensed clinicians. So that could be somebody with an MD, a DO, certified nurse midwives, advanced practice practitioners, mental health clinicians, MSW, LICSW. It's pretty comprehensive. They made it incredibly robust. I would say the inclusion criteria is much bigger than the exclusion criteria for who the state considers a licensed clinician. And they don't break it down by what type of licensure in the letter of the law. They just say licensed clinicians who have treated a patient or a client within the last 6 months.
Thank you. And then I will give the mic to Jack if he wants to pose this question.
Sure. Thanks, Alex. And Ned put something in the chat so we can come back to Ned. Hey, Annie, it's Jack McDevitt. Good to see you. You did a great presentation, and the research is really important. And just want to encourage you to keep it up. I wanted to see if we could dig a little bit into the data, um, being geeks of data. Uh, in terms of the getting the clinicians involved, if we look at around the country, what percentage of the ERPOs, roughly, would you say come from clinicians rather than law enforcement, rather than family members?
That's a great question. And honestly, right now we don't have that data. We don't even have it in Massachusetts. That's another ask that I'm going to be making of the trial courts is if we can get, they have, I believe they have race and they have gender of the petitioners, but they don't have petitioner category, whether it's family member, household member, in other states, law enforcement. One of the challenges of analyzing a policy like this is that the rollout statewide and nationwide is incredibly is distributed in a very, very haphazard fashion. And so there's really almost no two states that are the same as far as having the same petitioners or the same hearings. And so currently there are 7 states in DC that allow clinicians to petition, but I haven't seen a data dashboard or actual numbers come out yet for how many clinicians are actually petitioners out of all of those. And some of the data is actually really, really young. A year ago, this month, I think it was Michigan was able to implement their own clinician petitioner category. And so some of the data we just haven't gotten back yet. As you saw in the data dashboard, we don't even have updated numbers for 2025 in Massachusetts yet. So with most of these laws coming online, most of the ERPO laws in the country came online as a response to the Parkland shooting in 2018. And so a lot of that data, you've got 2018, 2019, and then all of a sudden we've got COVID and kind of throwing a wrench in everything. And so I think, what RAND did and finding that there's limited evidence is more, as you see time go on, we're going to be able to have better, more robust data, not just looking at how many petitioners are clinicians, but in all the different variables associated with the ERPOs.
Yeah, that's great. It caused me to think of, when the work I've been doing has been in hate crime. And so when hate crimes first came out, there was the same situation all across the country. Different groups were protected, different kinds of rights were uh, included and excluded. And interestingly, Ruth, from your perspective, it was the Anti-Defamation League that put together an annual chart that had the characteristics of each state so that you could then sort of start to see what were the trends, which groups were starting to get more. And so, I mean, there may be a Boston Medical Center, BU, Coalition, maybe, so there's some role to start to collect just the characteristics of the state laws as they shift. I'll get off, and my last question is, so the New York example is really interesting because they have restrictive legislation, not
Mhm.
as good as ours, but they do good.
Yeah.
But we're talking about 5,000 ERPOs
Hmm.
versus whatever is 11 or whatever. And they have a bigger population, but it's only 3 times the population of Massachusetts.
Hmm.
So maybe there's a case study there to sort of say what's going on in New York that we could find as best practices, because it seems like they're doing more than just having more people to be able
Yeah,
to get that kind of. I mean, as you point out, Connecticut's the leader because they've got, they started in 99.
right.
But New York came later to the party, and there might be some places there. So it's just a suggestion that might be a case study that we can all learn from.
Yeah, it's interesting. New York really just stands out, and I think, and this is just anecdotal from a lot of the different papers that I've read. I think it may come down to messaging. If you've got a attorney general or you've got a DA in a different county that's really feels that these are a useful tool and will promote it and promote it widely, you're going to see more usage. You're going to see, more. Their data is incredibly comprehensive and updated incredibly regularly. So I think you just have a more robust infrastructure built around it, maybe even a better implementation rollout plan when this came on board. But I think really it comes down to messaging because if you have an attorney general and you have different district DAs that are really, really invested in using a tool, you're just going to see the uptick in it. But great question. Thank you so much. I appreciate it.
Thank you. And I don't know if Ruth, you have anything to add to that one.
It's funny because the next question is coming from our friend Ned, who, like Jack, is also on our coalition board. And I just was remembering, Ned, of us doing some work with the trial court shortly after the ERPO law was passed to get their partnership and making sure that folks, court personnel really understood this. And then the pandemic happened and did really derail a lot of that work. So Annie, to your point that COVID really impacted how folks think about ERPO and whether they know about it, I think it was very much the case in Massachusetts. So I just wanted to touch on that a bit.
Thank you. And then going on to Ned's question, do the gun owners who are the subject of an ERPO get angry, vengeful, or more violent when and if the gun are returned?
I can't really speak to that. I don't know. There's nothing that's been documented. I haven't seen any case studies. I haven't seen anything in the news necessarily that would indicate that. If, in the case of clinicians, they're going to be assessing the respondents from a clinical perspective. And that could include whether they need to extend the ERPO or not. And if there was any clinical indication of any kind of anger or retribution or anything, I think that would be documented and that could possibly come into play with the extension or of the ERPO order or any communication with the court or family members or law enforcement that are helping to enforce the order. But unfortunately, I haven't heard of anything, and there hasn't been anything documented regarding any kind of retribution or anger or vengefulness.
And just to follow up, offer one other piece of data on that is, as Ruth knows, um, the police have been taking guns away from folks with domestic violence
Hmm.
restraining orders for years.
Yeah.
And it's something that we thought when we were trying to do that with the law that it would be some pushback from the police. And the police were like, we already have a whole set of policies about
Right.
this. We
Yeah.
know how to do this. We know how to do it with somebody who's been violent. We know how to do it with somebody who's maybe suffering a mental health crisis. So, they feel confident that they can execute it. Now, the clinicians are in a different place because they might have the relationships, with the whole family that might get involved here. So it's complicated, but there is some basic infrastructure there, Ned, that will allow us to sort of do this in a safe way for at least for the people who are taking the guns out of the house.
And if I can just jump in because Jack took the words right out of my mouth. And I also wonder too about how, since we've had as a domestic violence survivor advocate, knowing that we've had a robust process for firearm relinquishment in the cases of DB for many years now, if that also impacts actually our lower utilization of ERPO because folks are doing that also through restraining orders too. And I just wanted to highlight the importance of safety planning and clinicians talking with folks about exactly what Ned brought up, because I think it's important that we're holding safety in the conversations around accessing court support at every step of the way and recognizing that this is bringing law enforcement into someone's home. And there's a lot that we need to acknowledge with the implications of that too.
Thank you both. That was very insightful questions everybody put forth. I don't see any other ones. I'll pause for a second in case there is. Perfect. So we'll move on to the final component of this lunch and learn, which is our call to action. I'll hand it back over to Annie to begin with the main ones that she had given at the end of her presentation.
Yeah, I really want everybody to remember that this is our lane. This is not just for clinicians. This is not just for family members. This is not just for law enforcement. This is for all of us. And it really starts, with a conversation. And like I said before, Ruth and I talk about how important conversations are one-on-one or in a group setting like this, because it really creates ripple effects. And if clinicians start to hear from a lot of their patients, hey, what kind of conversations are you having with other patients about gun safety? Is this something that we can talk about? Is this something that we can plan? The more they hear it, the more it becomes important to them. And then maybe they'll say something to their colleagues. Maybe they'll say something to their healthcare system to start getting standard operating procedures on board for clinicians who want to file these for patients who are at risk or in crisis. So, this really is all of our work. It's all of our jobs to have these conversations. Patients having the conversations with your clinicians, clinicians having the conversations with your patients and colleagues and healthcare systems, getting involved with the Yes for a Safer Massachusetts campaign and also voting. All lots of homework for everybody, but I think we can all handle it in this class.
Yes, thank you. And I think just one final point that I remember when we had our first discussion is also just asking your clinicians, ensuring that each of us on this call are comfortable with having that conversation with a doctor, and even asking them, are they familiar with firearm safety and safe storage resources to ensure that, anyone in their network that may need it, is seeing a physician that is qualified and being able to provide those responses and answers. At the end of the day, our goal is to make firearm storage discussions on making our community safe at the precipice of the coalition's work. So thank you for all the questions and the insight, Annie, and I'll pass it to Ruth to give our final call to action.
Yeah, so you've been hearing us refer to vote yes for a safe Massachusetts. And I am going to take a few minutes just to tell everyone a bit more about that campaign and how it completely relates to our conversation today. So the other hat that I wear is, and I am the chair of this campaign. Again, it's called Vote Yes for a Safe Massachusetts. Tiny bit of background. The legislation we have been talking about was passed in July of 2024. Many of us here on the screen were honored to be in the room when the governor signed it into law. It was a very celebratory moment of knowing that we had accomplished this major piece of legislation. But a few weeks after Governor Haley signed it into law, we found out that the local arm of the NRA, or GOAL, the Gun Owners Action League, was collecting signatures to put a question on the 2026 ballot to repeal the legislation in its entirety. So folks should know it's 112 pages of legislation and includes this incredibly important piece around expanding ERPOs. It also includes regulating ghost guns, a piece around crime gun data analysis, including a publicly facing data dashboard around trace data collected from guns in the aftermath of shootings, a piece around how we look at CV, community violence intervention funding, guns in polling places, and so much more. There's a lot that's in this legislation. And the folks who are trying to repeal it are trying to repeal the law in its entirety, not taking issue with specific policies, but getting rid of the entire thing. And a note about who they are in the world. Those folks have formed their own campaign that they are calling the Civil Rights Coalition, ostensibly to fight the worst civil rights infraction in Massachusetts history. And so I don't need to tell you all, but that is incredibly ahistoric, but also incredibly racist. And that is basically their orientation to opposing this legislation, and saying that they don't want any of these regulations in place. And we have now formed a committee, again, called Vote Yes for a Safe Massachusetts. There are folks on the screen who are very involved in this work as well, to make sure that we protect this legislation from repeal. It is actually, of all the chatter about ballot questions, this is the only one that we know for sure is certified to be on the ballot this coming November. It is the only one that is a referendum, meaning it is a vote to repeal an already existing law. All of the other questions that will be on the ballot will be about making new policy. This is about protecting the policies that have already been passed. And most importantly, we need to vote to make sure we protect this legislation, but we also want to send a strong message that we don't want gun extremists coming to Massachusetts and dismantling the foundation that we have built. Our work is to make sure that we continue to move gun violence prevention policy and practice forward, but we cannot do that unless we protect the foundation that we have already built. So, Caitlin, as a member of our team, is putting some information in the chat, both a website about the campaign, a one-pager, but we want folks to be aware of this campaign, the work ahead to make sure voters know that they have a choice to make in November around voting to protect this legislation or not, so that all of this work that Annie is doing can continue to move forward, that we can continue to regulate ghost guns, we can continue to have a more robust process of tracing, of having information trace data from firearms and address gun trafficking that way, that we continue to have policies that we know are data driven and that actually protect our communities from gun violence, because that's what this work is about. There's nothing in this legislation that disrupts a legal pathway to owning a gun. It is all about putting regulations in place that keep our communities and our children safe. So you'll see more in the chat about Vote Yes for Safe Massachusetts. Our other call to action is to follow the campaign. Check us out on social media. We're on Facebook and Instagram. Share our information, whatever you can do to support this work, to spread the word, and to raise awareness about the importance of this vote in November. We will gratefully accept your help. So that's our last call to action for today. And we have 2 minutes to spare, so I'm going to end with some gratitude. Thank you again to my friend Annie Buck for spending time with us, for all of the work that you are doing to move this forward, to educate folks about this important tool, and to make sure folks understand we do have ways of making sure folks can be safe in a moment of crisis. We just need to utilize them. And I thank you for your partnership with the coalition. The coalition is always stronger when many voices are represented from many different fields and many different communities, and you're a big part of that community. So thank you. Thank you, as always, to Alex for putting together a terrific program today. And thanks for all the great questions from the audience. And just to all of you for being a part of our coalition community and being involved in this conversation today. This is also how we move the work forward, is folks being in conversation, telling their friends and neighbors about what they learned, and helping us really spread this important information. So thank you again. I'm glad you could join us. I hope you all stay warm, and we look forward to seeing you all again very soon.